Okay, hello. This is going to be our videos for this week. Up on Blackboard, I will have posted the slides for this set of lectures, L14, Chapter 20, Antimicrobial and Antifungal Medications. So if you get into that set of PowerPoints, you should see that slide 1 with the blue top says antimicrobial medications, and that tells you where we are in the book, page 502 to start out with. Section 20.2, the characteristics of antimicrobial medications. So I'm going to be breaking these lectures up into little segments, and then I'll be posting those segments, and I'll be giving you, well, if you're seeing these, you'll have worked out how to get to the links. So let's look at slide 1, characteristics of antimicrobial medications. We'll look at what is selective toxicity, the different ways that antimicrobial medications can affect bacteria, the difference between broad and narrow spectrum. We'll look at this thing called tissue distribution, metabolism and excretion. We'll look at the idea of half-lives. We'll look at some adverse effects of taking antimicrobials. We'll look at a very brief view, look at how microbes can be resistant. So on to slide 2. So someone goes into a hospital and they're sick. So this first part is about antimicrobials, more in particular about antibiotics, antibacterial. So you go into the hospital with a bacterial infection and you want to be given a drug to cure that infection. You then hope that the drug is going to kill the microbes but not to do too much damage to you as a human. And we can look at that idea between the toxicity between the bacteria and the human as what's called a therapeutic index. So we can imagine a dose of drug. At a certain level, we hope that the drug will start to kill the bacteria. Kill them, or maybe just slow them down. But bacteria are cells. Bacteria, although there are significant differences between you and a bacteria, the basic fundamental aspects of bacteria, them being cells and having membranes and having DNA and having proteins and having ribosomes, typically means that at some point, if you increase and keep increasing that dose, you might start to hurt the patient itself. The therapeutic index is all about this distance between where you start hurting the bacteria and then where you start hurting the human. If the therapeutic index is low, it means that there's not much of a gap between where you're hurting the bacteria and where you're hurting the human. If the therapeutic index is high, that means the gap between hurting the bacteria and hurting the human is bigger. So we want to really get the best kind of drug is going to have a high therapeutic index, in that we can really bombard the bacteria, kill them, or at the very least stop them from growing, but we won't ever reach the levels where the human being is going to be affected too. We call it the therapeutic dose. It's the dose that we give the human. That's the dose at which the drug is affecting the bacteria. So some medications, penicillin G for example, has a high index. And that's really one of the key ideas here in our antimicrobial medications, is trying to find all the things between a bacteria and between a human that are the most different. And one good thing we'll talk about a lot is that bacterial cell wall made of peptidoglycan. Human cells don't have peptidoglycan. Bacteria cells do. And that peptidoglycan is very important in how a bacterial cell functions. So if we can attack the peptidoglycan, that means that the drug is going to affect the bacteria, has very small chance of affecting the human. Because if we interfere with peptidoglycan synthesis or some aspect of peptidoglycan, that won't be a factor in the human cell. So drugs like penicillins, penicillin G for example, has a high therapeutic index because its target is those bacterial cell walls and their peptidoglycans. You can still use drugs even if they have a low therapeutic index. Many topical medications. So topical means that you apply it to the skin or you apply it to the mucous membranes. And then on slide 3 here, antimicrobial action. Many antimicrobials are bacteriostatic. So the static part means that stationary. So bacteriostatic drugs, they just prevent bacteria from growing. And then you rely then on the patient's own immune system to kill the bacteria. So the bacteria gets into the body. If it kept growing, it might overwhelm the immune system. By holding it at a level, our immune system then is able to clear those infections. Other antimicrobials may be bactericidal, like suicide or genocide or all those side. Bactericidal, killing. These are chemicals that kill bacteria directly. On to slide 4, characteristics of antimicrobial medications, spectrum of activity. So you may have heard of the term of broad spectrum antibiotics or narrow spectrum, and I think those terms make a lot of sense. Broad spectrum antibiotics are given to people and they kill a wide range of different bacteria. A narrow spectrum antibiotic is going to give to a patient and only kill a small number of different bacteria. You go into the hospital again, you have this bacterial infection, you don't know what it is, so the doctor might give you a broad spectrum antibiotic just to knock everything down and start helping the patient feel better, start to work on that infection. But it's not a wise long-term strategy. You want to give them that broad spectrum antibiotic and then you want to find out exactly what they've got. And as soon as you found out what the microbe is, you want to attack it with a drug that is, as best as you can, only going to kill that microbe and leave everything else alone. Because as we talked about before, we have in our bodies, a whole host of microbes. And many of those microbes help us. Our normal microbiota is a very important part of being healthy. We'll look at some ideas of what happens when you disrupt the normal microbiota. You can give drugs, more than one drug, to try and help a person. Sometimes you can give one drug, a second drug, and those two drugs work against each other. And that's called an antagonistic relationship. You could give one drug and a second drug, and they may work together. So they're more effective than just the addition of the two drugs. And those are synergistic applications. We may give one drug, works on one part of the infection, one drug works on a different part of the infection, and they have what's called an additive effect. We'll take a look at some examples of at least one synergistic mechanism in drugs. On to slide 5, tissue distribution, metabolism and excretion. So the picture there on slide 5 is of the blood-brain barrier, and this is just to illustrate the idea that sometimes drugs can get to one part of the body easier than they can get to another part of the body. So if you are trying to design a drug that gets into the brain to fight a microbe there, it's going to be a lot more difficult. You're going to have to overcome particularly this thing called the blood-brain barrier in treating, say, meningitis. So getting your drug to its target location, that's one thing to think about when you're designing or thinking about picking a drug. On to slide 6. Some drugs you can take as pills. When you take a drug as a pill, it goes down your throat, goes into your stomach. And one thing you may be aware of is the high acid level in the stomach. And if the drug is going to be destroyed by that acid, then there's no point giving it as a pill. If the drug will be destroyed by the acid, it may then be the case you get the drug as an injection instead, and then it bypasses the need to go through the stomach. When you take a drug, it's going to be eliminated from your body. Again, different drugs will be eliminated at different rates. And we can describe the amount of time that a drug hangs around in your body as its half-life. So half-life is the time it takes to halve the amount of drug in the body. And this is why you go and take your medication, and one drug says take one pill every 6 hours. Another drug can say take one every 24 hours. Because those two drugs are being excreted in a different way. And the example here is penicillin V. You take it 4 times a day because it has a short half-life. And you have to keep taking it because you want to reach that therapeutic dose. So you take your first pill and then it wanes. And you take your second pill and that wanes. And the third pill. So you are maintaining your the drug. A drug like azithromycin, you take that once every 24 hours. You take it once, and then it just hangs around in the body. And it's there for the whole day. You don't have to keep replenishing that drug. The ability of your body to excrete drugs is going to be affected by say, kidney and liver function. So if someone has kidney and liver problems, you might change the dose of the drug. Because you don't want a person who is having a hard time excreting, here's that therapeutic dose that kills the bacteria, here's the therapeutic dose that kills what it starts to hurt the human, and you give them a drug and it takes them a long time to excrete that, and then the next dose will increase that in the bloodstream, and the next dose will increase that in the bloodstream. So instead of giving doses and having it stabilize, you are giving them too much, and the dose is just increasing and increasing the amount of drug in their system, and maybe then pushing it towards a level where it's going to be toxic. Slide 7, adverse effects. So, you may have heard of penicillin allergies. Those can be life-threatening. We'll talk about what anaphylaxis is later on in the semester. And there are some drugs where that therapeutic index is very low. You'll go into the hospital again with your infection. They'll start you off on the safest choice of drugs. But if that safe choice of drugs isn't helping you, they'll move you up to maybe another tier of drugs. And typically, as you progress through the system of drugs to try and treat your infection, the therapeutic index gets lower and lower until, if you are an unlucky recipient of a antibiotic resistant bacteria, you may be taking a drug that is very toxic to your own body, just in hopes that you can kill that bacteria. So some antibiotics are used as a last resort. Many antibiotics and almost all drugs can have side effects, particularly for pregnant women. You want to be very careful about taking drugs in that situation. On to slide 8, more adverse effects. This comes down to the idea of disrupting the normal microbiota. So you can imagine the lining of your large intestine. That lining is covered in what we may call good bacteria, or at least bacteria that aren't harming us. And then when, say, a C. diff endospore gets into our body, it has nowhere to stick and it just is expelled. So one important thing that our normal microbiota does is they just cover our surfaces. And that means that harmful bacteria can't, harmful bacteria can't then kind of stake their claim. But if we use a broad spectrum antibiotic, we start to kill these bacteria that are colonizing our large intestine. Now we have lots and lots of space, and our Clostridium endospore gets in, and it lands, and now it has very little competition. Many of these kind of infections are opportunistic. They can only become a problem when they have the opportunity. And you can see here the outcome of a C. diff infection that's overtaken someone's intestine, most likely after they were treated with broad spectrum antibiotics. Now, how do you treat this? You may have heard of fecal transplants, in that you're trying to re-establish the normal microbiota in the colon of a person. By re-establishing that normal microbiota, you are then forcing the C. diff out. They're not very good at competing, so you introduce lots of good, or at least not harmful microbes, and they start to outcompete the C. diff. On to slide 9, resistance to antimicrobials. We'll take a very more detailed look at resistance, but resistance is something that you may be familiar with. You may be hearing about different kinds of antibiotic resistant bacteria like MRSA. We'll look at things like innate and intrinsic resistance. We talked a lot about mycoplasmas and their not about mycobacterium. Mycoplasmas are a little bit different. They don't have a cell wall. And we'll look at the idea that many of our drugs attack the ability of the bacteria to build its cell wall. So if you don't have a cell wall to build in the first place, then you are kind of immune to all those cell wall drugs. Look at the difference between gram positives and gram negatives in terms of how they are affected by medications. We'll look at what a plasmid is, how one bacteria can have this thing called a plasmid, and it can pass that plasmid on to its neighbors, and it can just give them resistance to antibiotics. So, slide 10, some of the things we're going to be looking at. We were looking at drugs that affect cell wall synthesis, drugs that affect protein synthesis, drugs that affect nucleic acid synthesis, that affect metabolic pathways, and that affect cell membranes. Okay, so on to slide 11 with the study guide. What is a therapeutic index? That is the level at which the microbe is killed by a dose of the medication, and compare that to the level that the human might start getting hurt. The closer they are, you're killing your microbes, but a little bit more drug will start to hurt the person. That has a low therapeutic index. A little bit of drug, a little bit more, you aren't killing or hurting the person. This has a high therapeutic index. Some drugs are bacteriostatic. They just want to hold the population of bacteria at a certain level, and then your immune system can start picking them off. And some drugs are bactericidal, and they will kill the bacteria. Broad spectrum will kill lots of different things. Narrow spectrum will kill a few things. Downsides to broad spectrum is that they will kill all of the good bacteria and all of those neutral bacteria that are just living on you and using up that space. You would want to find out what the microbe was, find out which drug kills it, and as best you can, only target that one bacteria without affecting the others. Drug combinations, antagonistic, if they have kind of if they interfere with each other. Synergistic, if they help each other. Additive, when they're just both doing their job. We want to think about where the microbes are, and then that'll affect how we target our drug to them. Different parts of the body are easier or harder to reach. Metabolism, so our ability to take the drug and break it up, and then excretion, our ability to get rid of that drug. Some drugs can be taken orally because they can pass through the stomach and the acid won't harm the drug. Other medications have to be taken in an injection because they need to bypass that mechanism. Or they just need to get to different places. That's why we might take two different forms of how the drug gets in your body. Some drugs have to be taken more frequently than others because of their half-life, the amount of time they are present in the body. We want to maintain that therapeutic dose. So we keep on giving a drug, and the drug is then maintained at that level. So we are adding as much as is being taken away. Or a drug may have a long half-life. We can just give one dose and it just stays in the body. Adverse effects, side effects. Most drugs have side effects. Side effects of broad spectrum antibiotics is the disruption of the normal microbiota. And then we have opportunistic pathogens like C. diff come in, and then they start causing problems. Okay, that's enough for this first section. I will stop here and pick up on slide 12, looking at drugs that affect cell walls.